just introduce myself. I'm a neurologist who subspecializes in neurorehabilitation. So specifically, I manage the needs of adult patients after neurological injuries, especially those with spasticity. And next slide here, sorry. Okay, good. So I have no relevant financial conflicts of interest. I will be mentioning a number of services and products today, but I will not be, I do not have any financial relationships. Okay, so I'll be discussing the current understanding of the neuro-recovery process and provide an overview of the various standard of care and as well as non-standard treatments that are available, either commercially or through research. Then I'll end with some guiding principles for navigating this evolving realm of neuro-rehab resources. So we will first learn about neuroplasticity and how it is relevant to the neuro-recovery process. We'll discuss how to help an individual maximize their current standard of care based on the principles of neuroplasticity and neuro-recovery. Then we will explore potentially therapeutic novel modalities that are available, including emerging research interventions. And at the end, we'll consider general principles of treatment selection. So I'll start with a quote to speak to the human experience that occurs during injury and healing. So transformation is a process, and as life happens, there are tons of ups and downs. It's a journey of discovery. There are moments on mountaintops and moments in deep valleys of despair. So I see this, this quote as an analogy of the neuro-recovery process itself. So in the beginning, after a neurological injury, there is a phase of rapid recovery. You can call it the spontaneous stage of recovery. And then there's a phase of slow or minimal improvement, commonly but misleadingly called the plateau stage. And often during this so-called plateau stage, an individual may be discharged from skilled therapy and perhaps with the message that there has not been any more improvement and there's nothing more that we can do for you. But there is, we now know that there's more to this neuro-recovery story. Either an intervention or a focused effort can continue to spark progress. So I'd like to show you some examples of how some people have regained motor ability and continued their climb upwards to greater functional improvement years after a neurological injury. So the first patient experienced some significant functional improvements 2 years after her stroke. And her name is Sonia. She was 39 years old at the time of this video. 2 years after her stroke, which weakened the right side of her body. You may have heard about her from all the media buzz surrounding the Stanford stem cell research study. And this video will show Sonia's ability to move her arm before and after a neurosurgeon drilled a hole into her skull and injected stem cells into several locations around the area damaged by the stroke.
2 years later, Sonia could still hardly lift her arm, but just one day after an experimental treatment. Oh my gosh. Sonia could lift her arm over her head, move it to the side, move it to the side, and also to the front. And her words began to flow.
Okay, so that's our first example. And then the next individual was another, we call a super responder to an intervention called C7 nerve transfer surgery. This is a 30-year-old man who had a stroke when he was 18 years old that affected the right side of his body. His main difficulty is extending his elbow and his wrist. So you're going to see two juxtaposed videos. The one on the left is labeled baseline prior to the intervention, and the one on the right is 12 months later after the patient underwent a neurosurgical procedure called C7 nerve transfer, followed by 4 days a week of rehab for 12 months. Okay, so focus on the right arm. So shoulder movements intact, but previously had difficulty moving the elbow and the wrist, as well as the fingers. And this is after 12 months. Now looking at just the wrist movements. He's now able to have not full control of his affected side, but a functional amount. Now where he's showing the ability to grasp. And then he is able to after the intervention. Now he's demonstrating pinch, interacting with small objects, which he has been able to do afterwards. So what I am not telling anyone to go line up for one of these investigational treatments just yet, because there were significant side effects from these interventions, and only a very small number of people were studied, 18 patients in each group. So, so it remains to be replicated in larger populations. But what is common about these two patients where they were able to make tremendous recoveries years after a neurological injury, which brought new hope to counter the previous held notion that no further progress could be made after arriving at this seeming wall or plateau in the recovery. Okay, so what we think might be working here is a number of factors, but the major ingredient is neuroplasticity. So neuroplasticity is the ability to make and modify or take away neurons, connections, and networks of the brain. It dictates our brain function and ultimately our activities, our actions, our behaviors. So neuroplasticity is most active early in life, as indicated by this bump there. And then it does not go to zero. At some point, there is always a baseline amount. And so it just doesn't go away. But it does change in response to various life experiences. For example, there can be high levels of neuroplasticity activity, again, triggered after such events, such as a new brain injury, like a stroke or a TBI. And that is responsible for the initial stage of spontaneous neurological recovery. We have also learned that certain interventions, such as those used in the previous two videos, can also bump up neuroplasticity and lead to motor improvement, even in the chronic stage. So how do we apply what we know now about neuroplasticity to the treatment of patients with neurological injury in the chronic stage? So not only do stem cells and targeted surgeries boost neuroplasticity, but also we know that repetitive practice, certain medications, electrical stimulation, and many other interventions can do the same. So I'd like to start by discussing standard of care treatment options first, which directly and indirectly harness the power of neuroplasticity to improve motor function. So we are modulating our brains, strengthening specific connections between our brain and our muscles when you're actively performing repetitive practice with specific skills or tasks. And usually while working with a physical therapist or occupational therapist or on your own, as well at home, the principle to emphasize here is high dose exercise, multiple repetitions, which is the key here. So when navigating these treatment options, it's important to understand there are pearls and pitfalls. So first, it may or may not be common knowledge, but skilled rehab therapists can bill for maintenance services to prevent slow decline and to manage neurological conditions in the chronic stage. For example, a therapist can continue to see patients periodically to help them stay as functional as possible, even if no improvement is being made, but this is deemed to be clinically appropriate. Another common pitfall that I have seen is the need to find neurotrained therapists. So therapists also specialize in different areas, and this is why your mileage is going to vary depending on who you see, because the skill sets and the ability to individualize treatments to your needs and what can be offered are different. So this means for physical therapists, look for NCS certified physical therapists, and for occupational therapists, those who are trained and experienced in neurological rehab techniques. So because there is this variability in training and access to special equipment, there are treatment modalities that can be overlooked, such as electrical stimulation, a technique called neuro-recovery, sensory rehab, body weight supported training, mental imagery exercises, mirror therapy, joint mobilization, manual treatments, and customized or dynamic orthotics. So it's important, again, to seek out those therapists who have additional training in these areas. In addition, it's important it may be beneficial to consult with physiatrists, neurologists, and orthopedic specialized physicians who can offer additional medical interventions in conjunction with skilled rehab therapies. And I emphasize in combination for the best outcomes. This could be Botox treatments, intrathecal backbone pump, therapy, medications, and other surgeries in conjunction with physical therapy and occupational therapy. And for those who have severe weakness or spasticity, we know that those who have successfully been able to implement a daily routine of aerobic, range of motion, stretching exercises tend to avoid worsening of spasticity, preventing contractures, maintaining strength, endurance, and having less movement-associated pain. And so it is these home exercises that sound boring, but are in fact as important to encourage to maintain mobility as much as flossing and brushing teeth is to maintaining healthy teeth and gums. So of course, there could be multiple barriers that need to be overcome or addressed first, such as caregiver assist, motivational factors. And I've also added on therapeutic massage and acupuncture because these can be added on to a regular maintenance routine. And more, these are being covered by insurance and FSA plans. So just showing you some pictures of some of the types of trainings we talked about. This is body weight supported balance training as well as body weight supported treadmill training. This is a great way to increase your dose, right? When we're talking about being able to do more repetitions, off-weighting the body or the limb is going to be helpful for being able to do more repetitions. This next device or piece of equipment is a standing frame. In this case, it's actually an exerciser as well. So an elliptical exerciser that can be used by those who are unable to stand independently. So this is a great resource to have at home, and it is potentially covered by insurance. I also would suggest, so these are just pictures of Botox and an intrathecal backbone pump for the treatment of spasticity. Okay, so next I'm going to talk about some novel or non-standardized treatments. And these are just examples, so not an exhaustive list. So unfortunately, when we talk about these types of non-standardized treatments, it typically means out-of-pocket private pay modalities. But based on my experience, it has been worthwhile, even for those who are unable to afford the cost of these options, as there may be scholarships, there may be sliding scale options or reimbursable expenses, because some do find these additional strategies potentially beneficial and even life-changing. So for those who do have resources to increase one-to-one therapy time, you could hire private pay therapists who can come to the home, for example. And this allows for being able to implement a treatment plan that's not constrained by the constant need for insurance reimbursement justification. You can take the time that you need, which is really liberating. You can also go to a gym specifically designed for people who have neurological injuries. The top here are pictures from the SciFit gym. It's a spinal cord injury fitness gym, but it's not only for spinal cord injuries, for anybody with neurological injuries. And it's actually a powerful resource that can provide up to 2 therapists working with you at a time for those who do need the additional support. At UCSF, we have the FisFit PT Health and Wellness Center. That is also a gym that offers private pay one-to-one therapy or group sessions led by a neurophysical therapist, which is a good option when insurance runs out or one may need more intense therapy than once or twice a week. And the picture down here is of the Stretch Lab, which is a new resource that I learned about recently. For those who need others to help with providing routine passive range of motion and stretching exercises, especially those who might not have a caregiver who can provide this type of support. And it provides 1-hour sessions of muscle relaxation combined with stretching exercises. And usually it's important to do muscle relaxation in addition to stretching, which is better than stretching alone. Okay, so more, bringing onto the table more resources potentially. CIMT Clinics are private clinics that were designed to treat learned non-use. So after a brain injury that causes weakness, it is not uncommon for one to stop using weaker limbs, even though it is capable of movement, and instead rely on the less effective limb. And this is called learned non-use. And one way to combat this is to restrain the less effective limb so that it forces you to use the weaker side as much as possible. And this is a specialized technique that may or may not be easy to find, but it has been shown to be effective. So that is this picture right here. Now, down here is a picture of the neuro-recovery type of technique, which has it, and the originator actually is in the Bay Area. It involves precise hands-on handling by a therapist to improve function and the use of custom orthotics to help with positioning. So you might see that available out there. And then also, I want to point out gamified virtual rehab. Gamified rehab is one way to improve motivation to participate in rehab training. And there are a number of systems available commercially now for the home or clinic use. Some examples include, I'll give you some examples in the next slide. But I wanted to actually also talk about robot-assisted gamified rehab systems. So for those who have severe weakness, robot-assisted rehab involves donning in this case, it's a robotic glove that is able to provide you with assisted movements. And it's smart in a way that it can adjust, it can self-adjust how much assistance is needed, and then wean off that assistance as one becomes stronger or better while performing game-based rehab. So these are examples of the virtual and gamified types of devices that are available commercially. This is the Wii Fit. Oh, I'm sorry, I'm sorry, this is the smart, I'm blanking out on this specific system, but this is the music glove. And then below here is the NeoEffect Smart Glove and the NeoEffect, I believe it is the Smart, apologize, I don't have my my notes here. but okay, I'll come back to that. So other assistive orthotics that can be just used daily are the, we have the Myomo here and the Neo-Mano soft robotic. And these were made for distal weakness. These assistive orthotic robotics can be used to correct distal hand wrist weakness. So in other words, your shoulder, your elbow, it's working fine. It's just you can't open your hand and you can't control your wrist. And so, so these were specifically made for this situation. There are now 2 electrical neuromodulation devices available for electrical stimulation that is applied during rehab training to enhance the effects of the training. So one is the Vivistim for upper limb, so arm training, and the other is the PONS device. So the PONS device, as you can see here, it's actually a stimulation device that you place over the tongue, and it stimulates the tongue while you're performing gait and balance exercises. The Vivistim is an implanted device. It's completely implanted, and there's a wire that stimulates the vagus nerve along the neck, and you can turn it on and off while you are doing rehab exercises with the arm. And these were 2 newly FDA approved devices. We're going to move on to more research types of interventions now. Again, this is not an exhaustive list. So we talked about stem cell therapy here. I'm sorry, here. And this is where the surgeon injects stem cells directly into the stroke lesion site. And there is a phase 2 trial that is currently completed, but the results are not yet available. Here we have C7 nerve transfer surgery, which involves cutting the peripheral C7 nerves on both sides and then connecting the unaffected side with and then grafting it to the nerve on the affected side. And this was paired with rehab therapy for 1 year, 4 days a week. There's another type of treatment that facilitates neuroplasticity. And this here is called TMS, transcranial magnetic stimulation. And what it does is it sends a magnetic pulse, electrical pulse, and it can either facilitate or inhibit certain areas of the brain, affecting the neuroplastic process. So similarly, we have this transcranial direct current stimulation, which are these electrodes that are placed on specific areas over the scalp, and it provides direct current stimulation. And these 2 modalities can be paired with high intensity rehab as a way to prime the brain to make it more plastic and receptive to learning. Okay, and this next modality is BCI, or brain-computer interface. It is another area of research reserved for the most severely affected. It aims to retrain the brain to be able to interact and control one's environment, including assistive robotic arms, computer interfaces, and other systems. And they're doing this by using their thoughts. So I have a participant who jokingly says it's like training to be a Jedi. So this participant is being trained in a certain way to use their thoughts to control first a computer system, And the brain signals are being recorded through this pedestal and connector, and it's being routed, decoded by a computer. Then it's used to control this simulated arm on a computer, and then you can progress to controlling an actual assistive robotic arm. This is actually commercially available. And let me show you them. So he is using his thoughts to move the robot in 3D space. And he's able to grasp objects. This is very early type of study. And my final clinical trial here that I want to demonstrate is this is a type of pattern stimulation of the spinal cord that's able to help this man with complete bilateral leg paralysis be able to walk on his own. Well, with the assist of a walker. So here's a video of placement of, so this is the paddle that's being placed onto the surface of the spinal cord. And then it creates pulses in very specific ways, and it's individualized, so that it can produce synchronized movements of the muscles. And this is what we see.
Patients use activity-specific stimulation programs outdoors to walk.
So this was, so in this study, participants were able to perform standing, walking, swimming, and cycling activities. And while they were participating in a rehab program 4 to 5 times a week for 5 months. Okay, so so I hope that that you leave today with knowing that there are standard and non-standard treatment options available, and exciting technological advances on the horizon that can make a difference in the lives of those who have long-standing motor impairments. And I know it's hard to know where to start sometimes, and I would suggest starting with individual impairments, goals, and preferences. And it's okay to keep trying different treatments and approaches based on what's available, what individually makes sense to the patient, care providers. So I think I don't think I'll go into these. I don't have time, but I do want to, because health equity is the theme. I would like to emphasize that it's important to try to educate individuals as much as possible regarding what the highest quality of care might look like for them, and also, participating in research is another great way to access the latest technologies for all. Okay, so thank you.